Okay. So the very first topic that we have for today is the extradural hematoma. So you can take your time to read the scenario and then I will start asking you questions.
All right.
So reading the scenario, who will be the first person that you will be calling for help?
Okay. In this index patient, the first person I'll call for help is a resident. It's neurosurgeon
And anyone else?
and anesthetist.
Okay. So what investigation you will order in this patient?
Okay. In this patient, I will order for brain CT scan because yes, I'll order for brain CT scan. That is computerized tomographic scan.
Okay, so a CT has been provided as you can appreciate in the slide. So comment on the CT scan.
Okay, this is a CT scan of the brain that showed a biconvex hyperdense lesion on the right with shifts uh, to the opposite sides of the lateral ventricles uh, with some hyperdense, yes, with some isodense area around the biconvex area. So this is in keeping with acute extradural hematoma.
Okay. So would you have ordered a CT scan even earlier in this patient?
Yes, I will have order for CT scan earlier. I can order for CT scan earlier based on the presentation.
Okay, so what signs would warrant an earlier CT scan?
Okay, the signs that will warrant a CT scan in this patient is because of two episodes of vomiting and the uh, GCS start to drop. So in this index patient, because of two episodes of vomiting and the GCS is dropping, that is the indication for earlier CT scan in this patient.
Okay, so why do some head trauma patients have blown out pupils? Can you elaborate the reason for that?
Well, some trauma patients do have blown out pupils because of space occupying lesions when there is intracerebral hemorrhage or extradural hematoma, like in this patient, and there is compression of the oculomotor nerve. So that will give rise to uh, uh, the blown out pupils.
Okay, so can you describe what is the Monroe Gallery doctrine?
Okay, Moro Kelly doctrine is a hypothesis that states that brain is a rigid box that contains that has three main components: the brain tissue itself, the blood, is the cerebrospinal fluids. Brain about 80%, blood about 10%, and CSF cerebrospinal fluid also about 10%. That brain doesn't, the skull doesn't expand. It's a rigid box. So if there is increase in one component, there will be compensatory decrease in the other component in order to maintain the uh pressure, in order to maintain the normal brain pressure. So when there is increase in one component, there is decrease in the other component in order to maintain the pressure because the brain is rigid box. The skull is rigid box and doesn't expand.
Okay, so what are the ways by which you can measure the ICP?
Okay, ways to measure the intracerebral pressure to be uh, more invasive or less invasive method. One way is by using intracerebral intraventricular catheter. That is in basic way, it has it's more accurate. However, it has a disadvantage of being difficult to insert and the risk of injury and risk of infection. Another way is by using subarachnoid. That is their way. It's a bit safer, but it's less accurate. It has less infection. One can also use subdural also. Catheter to access the ICP. That is has less infection rate, but it's less accurate than intracerebral.
Okay, so what is the normal value of the intracerebral pressure?
The minimum hold of intracerebral is between 7 to 15 millimeter of mercury.
Okay, so can you explain what is lucid interval?
Okay. Lucid interval is an interval between uh, initial loss of consciousness after trauma and the deterioration in level of consciousness. That is between a lucid interval, an interval between initial loss of consciousness post-trauma and uh, deterioration of consciousness level hereafter, and the period of about 30 minutes to 1 hour. And this is result from gradual intracranial hemorrhage, most likely resulting from extradural hematoma, most likely from middle meningeal artery.
Okay, so can you describe the clinical picture of increased intracranial pressure?
Okay, if there is increased intracranial pressure, the clinical feature usually could be the sign nausea, vomiting. Somebody can help with that clinical symptom. The signs includes ocular edema, blown out pupils, and other signs are the pushing um, reflex, pushing the pushing the syndrome or pushing reflex, whereby patient will have hypertension, bradycardia, and irregular respiratory pattern.
Okay, so what are the different strategies of managing increased intracranial pressure?
Okay, one can manage increase intracranial pressure one by improving venous drainage or venous drainage from the heart, raising the bed of the head of the bed of patient to about 30 degrees position and stabilizing the cervical to reduce the increase intracellular pressure is by reducing metabolic rates of the brain. This can be done by ensuring uh, preventing hyperthermia, preventing uh, hypo or hyperglycemia, and preventing restlessness that consume restlessness by maybe giving sedatives. Another way to reduce the intracranial pressure is also by reducing the brain edema itself, the cerebral edema. And this can be achieved by giving uh, diuretics like mannitol, like fructamate. This can achieve, this can help in reducing the cerebral edema and subsequently the intracerebral pressure. Another way to reduce the the intracerebral, reducing the blood flow, ventilation, hypocarbia, hypocapnia, reduction in carbon dioxide and subsequent vasoconstriction and reduction in cerebral perfusion pressure and subsequently reduction in blood flow. So these are uh, some of the measures to reduce the intercerebral pressure.
So, what will be the effect of traumatic chest injury on the cerebral perfusion pressure?
Okay, effect of traumatic chest injury to cerebral perfusion pressure. It might increase cerebral perfusion pressure, might increase in traumatic injury because the traumatic chest injury can give rise to uh, pleural effusion or pneumothorax with subsequent difficulty in breathing, with subsequent accumulation of carbon dioxide. The accumulated carbon dioxide will subsequently give rise to dilation of the cerebral blood vessels and increase in cerebral blood flow. So the cerebral blood flow will be increased if there is uh, uh, hypercarbia, if there is CO2 retention because of uh, difficulty in breathing. Another way it can reduce it is if there is massive pleural effusion with blood loss and hypotension. So because of hypotension, there will be a reduce in blood flow and subsequently a cerebral perfusion pressure can be reduced.